Hi everyone, my name is Jasmina Alagic and I'm an accounts manager here at Erchonia EMEA. Thank you for joining us on this enlightening webinar on peripheral nerve entrapment, common pain presentation presented by Dr. Jake Cooke from the Neuromuscular Clinic. For those of you who don't know Dr. Jake is a graduate of the AECC, a diplomate of the American Chiropractic Neurology Board, and has a master's in musculoskeletal neuroscience. His focus is on chronic pain and dizziness, balance disorders. He is the current chairman for the European Academy of Chiropractic's Neurology Special Interest Group, with the goal of showing how neurology can be used to improve your assessment, treatment, and outcomes. We will be happy to assist you further at the end of the webinar, which for your reference will be recorded and sent out to all the attendees. I would like to alert you to the question and answer box on the right-hand side of the screen, which you can type the questions to Dr. Jake. Okay, well, without further ado, over to you, Dr. Jake.
Fantastic. Thanks so much for that introduction. Hello, everyone. Good evening. Thank you for joining tonight. I know there's a lot of things that could be pulling you in different directions, so I appreciate you taking the time to spend some time with me. So today we are going to be talking through peripheral nerve entrapments, or the most common ones anyway. What was that showing? No, good. Give me 2 seconds. Let's get that working properly. Good. Hopefully you should now see an actual presentation and not just some home screen. So today we're going to be talking through common peripheral nerve entrapments. Now this is a huge topic. So really we could spend a week of seminar every day talking about all the different aspects of peripheral nerve entrapments and neuropathies. But the majority of us are probably manual therapists, so physios, chiropractors, osteopaths in that kind of world. So apologies if I miss out any other kind of forms of manual therapy, but I'm going to group us all under one umbrella. So when we look at these kind of complex diagnostic patterns, where we could say everything from alcoholic polyneuropathy to Charcot-Marie tooth disease, really for most of us, we're not going to see it very often. And so I've spent a lot of time bashing my head against the wall, trying to find ways to memorize all the information and to learn every nerve, its innervation, the things that affect it, all this kind of stuff. And then I forget it because I don't see it enough in practice. And so over time, every time I revise this stuff, I found myself being more and more specific to the things that we really see in clinic. So when we look at this diagnostic approach, really the stuff in the middle is what's going to be most relevant to us. So these mononeuropathies. So when we start looking at multifocal neuropathies, that tends to be other stuff that has a more sinister origin that we'd have to refer out to. So, and when we look at polyneuropathies, again, straight away, we're going to have further testing. So whether that's an alcoholic polyneuropathy or diabetic polyneuropathy or an ascending sensory motor polyneuropathy, as soon as we have that kind of presentation, we're going to have to refer out for help for further investigations and treatment. So really the things that are just your simple peripheral neuropathies, just one nerve at a time, whether that's a radiculopathy in the cervical spine or a peroneal nerve lesion at the knee because someone got kicked, that's the majority of stuff we see. And the majority of those are going to be mild. So mild or moderate, but severe. Whenever you see severe, really, if you're a manual therapist, we're probably not the lead ones treating that unless you work in a hospital setting alongside a surgical team. So severe cases for neuropathy are always going to end up having some kind of surgical intervention. Always is always the word you should never say always, but most likely. So we are most likely going to see slight, mild, or moderate, and that goes for most things. So that includes pain. Really, if someone is in really severe pain, there's a good chance that you're working as part of a team, or you've got someone else to take an MRI or X-ray or do something with it. So sometimes I think what we do is very difficult because we don't have access to electric diagnostics and MRI and ECG and all these different things. On the other hand, what we do is it's kind of easy because we don't have to look at all that really complex stuff. So there's more than 25 different peripheral neuropathies that have been well documented, but really it's far more than that. So there's 25 that are kind of commonplace, you'll find in most neurology textbooks. You know, if you pick up a neurology textbook called something like localization in neurology or differential diagnosis in neurology, things like that, there's the classic ones that you'll find, which would be some of the ones we'll go through today, but also things like greater occipital neuralgia or myalgia paresthetica and things like that. So the important thing to know is that we can have a peripheral neuropathy wherever a nerve passes through a tunnel. So whether that's an osseous tunnel, like the tarsal tunnel syndrome, where the peroneal nerve, posterior peroneal nerve is going to pass under a ligament and between bone. So that's a classic kind of entrapment site. Or we can have muscular entrapments, where, again, we call it a fibromuscular entrapment, where a nerve is passing between maybe two different heads of a muscle. And if those two heads are hypertonic for a long period, or they've become a little bit fibrous, or the nerve itself has become a bit fibrous, it can get entrapped. Or some nerves punch straight through the bellies of muscles to get to other places. So a classic example of that would be back pain. When we have back spasm of those erector spinae muscles, where we've got these big, powerful extrinsic muscles that compress, well, to be able to feel sensation to my skin, I have to have these little small nerve fibers that go through the muscle to get to the skin. So when those muscles are spasming and they're contracting all the time, those nerves are getting pinched all the time, and they start to become hypersensitive. So you could argue that actually quite a lot of the pain syndromes that we see are a form of neuropraxia, that there is a compression of those nerves. And there's also an argument to be had that when we talk about trigger points, are we really searching for this thing that we can kind of theoretically describe but can't open up and point at? You know, you can feel it, but you can't surgically open up and say, I see a trigger point. So there is a question there of, are these trigger points really nerve entrapments? So let's have a look. So peripheral neuropathies can occur acutely, but the vast majority are going to be chronic in nature. So an acute example would be something like a stinger. So if a rugby player goes in, takes a tackle, and they have a hard whack to the top of the brachial plexus, they have an acute peripheral neuropathy. Or football players who maybe get kicked in the side of the knee might have an acute peroneal neuropathy. So in that scenario where we have a blunt trauma, we're going to have temporary dysfunction of that nerve, and if it's severe enough, we might have some myelin damage, which will mean that it will take weeks or months for the nerve to recover. But the vast majority are going to be chronic in nature, which means that they are from maintaining certain postures a lot. So classic one would be someone sitting in a chair behind a desk in this slumped forward position. So if we stay in one position for long periods of time, another example would be carpal tunnel syndrome. So someone classically will sleep like this. For some reason, I don't know, I find that incredibly uncomfortable, but a lot of people like sleeping like this. You close off the carpal tunnel, the nerve gets compressed during the night, it can't drain, the venous drainage stops, we get edema, patient wakes up with numbness in the hand, but once they move their hand around and shake it, that blood flow is restored, the edema drains, and their numbness goes away. So a lot of chronic ones are initially going to be resolved by changes in postural movement. And again, when we see a lot of people with back pain, if you start paying attention to where these nerve patterns are, and we'll discuss these later on, but for a classic example, be someone sits at a desk and they complain about burning pain in between their shoulder blades. Well, often they're literally pointing to like where the nerves run. So there's a dorsal scapular nerve that runs down that medial border of the scapula. That's literally, you can follow it all the way down. That's where it's hurting. Well, if you look at the pathways of that, it passes under muscles, so between upper traps and levator scap, and then has to run underneath the rhomboids. So if these muscles are very tight, where these nerves go between one muscle and another, we can get these compressions. So I think a lot of what we see in manual therapy is often these peripheral nerve entrapments, and they're all on a scale. So it's not just as simple as it's either broken or not broken. We have this gray scale of, is it just partially some of the time in certain postures, or has it moved up the scale, so now it's very persistent to the level where it's severe and we have significant nerve damage. So let's just remind ourselves of the nerve anatomy. So in the one nerve cell, one neuron, it has the cell body, and we have this axon that runs down the length of the cell. When we're looking at sensory cells or sensory neurons, their cell body is going to be in the dorsal ganglia. Now, we have individual axons, and then groups of axons are going to run together in fascicles. So if you look at the most out protruding part, you can see endoneural vessels, axons, and you can see that endoneurium wrapping around them. So the endoneurium is the innermost layer of connective tissue, and its goal is to resist stretch, which is really important. So if you take your elbow now and we say the ulnar nerve is at its normal position, and then we bend the elbow, by the time I bent the elbow, the ulnar nerve has had to stretch by around 55%. So you can imagine if we didn't have endoneurium that protects those fibers while they're being bent or while they're being stretched, we would damage those axons very, very quickly. So the endoneurium, its job is to surround those fascicles and protect them from stretch. We'll talk about why that stretch is so important in a minute. The next layer out is going to be that perineurium. So we've got endoneurium, we're then going to have blood vessels, and then we're going to have perineurium wrapping around that. The perineurium's job is to maintain physiologic milieu, which is a fancy way, slightly ridiculous sounding way, of maintaining homeostasis. So basically, its job is to maintain the correct environment for the axons and for the endoneurium. So that's going to make sure that it has a blood supply that can come to and from, and that basically, you know, we can drain things away, we can bring any building blocks or energy that those axons will need. And then the last part is going to be the most outer layer, which is your epineurium. So that really is going to wrap, if we look at that diagram, we can see those three different perineuriums with those axons and epineuriums right in there. The epineurium is going to wrap around all of that, and it's going to provide protection against compression. Interesting with that is you're going to see that there's going to be greater epineural layers, so it's going to be thicker wherever nerves cross joints. So wherever there's a point where that nerve is going to get compressed, like again at the, let's say now the median nerve, as I bend my elbow, median nerve is going to compress, it's the epineurium that's going to protect me from that. Whereas on the other side, we've got the endoneurium protecting the ulnar nerve. So these layers are incredibly important. When they get damaged, that's when we start suffering and having nerve damage. But all of these as a total are the nerve itself. So nerve entrapments. Like I already said, they can occur at any sites that have these fibro-osseous sites or these fibromuscular sites. So basically wherever we have a tunnel. Now, the reason it causes damage is it's actually the blood flow. So it's a bit like a compartment syndrome in the anterior tib, where if we can't get the blood out, the pressure starts to build because more blood is starting to come in, and that increase in pressure causes huge amounts of damage. It's just like that with the nerve. So if I have a nerve here and I start to squeeze it, we get venous stasis. So basically the blood flow, the venous system can't drain the blood away. The pressure starts to build. We start to get edema in the surrounding tissues, and that edema starts to compress the nerve. The nerve can take that for a short period of time, but it can't do it for long periods, and it can't do it with high repetition. So it's really that venous status that's causing the damage. Now, the brachial plexus is a wonderful example of this because we can see the upper brachial and lower brachial plexuses there, so C5 to T1, and we know that we're going to have, it's like a stinger is a great example of that upper brachial plexus lesion, where someone's had the shoulder has been depressed, and we traction the upper brachial plexus, and we end up with the injury there. Or we can have these lower brachial plexus injuries, which would be the opposite, where maybe someone pulls my arm, or no one's going to pull my arm strong enough to damage my brachial plexus. But let's say I like rock climbing. Let's say I fall, and I instead of falling to my death, grab a tree branch, and my arm goes. That'd be another classic way to really avulse or damage that lower brachial plexus. But if we look at the rest of it, we can have a muscular entrapment from the scalenes. So the anterior and middle scalenes can compress the brachial plexus as it comes out, classically going to hit C8, T1. That would be that pain into the proximal shoulder, down the medial aspect of the arm, into the ulnar nerve distribution to the fingers. Or we can come further out, and you can't see it here, but if we look at where the pec minor would attach, so it's going to go from the ribs to that coracoid process. Again, the brachial plexus, C8T1, that medial branch is going to go down underneath pec minor. So we can get that compression there too. So basically, although we say there's 25 different of them, you point at a nerve and show me the pathway, and at some point you'll probably see that it will pass through a notch of some kind, whether that's bony or muscular, or punching straight through a muscle itself. So we can have them, everywhere. Mane syndrome was a classic one that used to get described, and that was thought to do with the joints. But nowadays we tend to say, well, maybe it's not the joints referring that pain from the kind of TL junction down to the pelvis, but maybe it's these nerve fibers that come down to give us a sensation to the top of the pelvis and round into the groin. So things like the genitofemoral nerve, apologies, and all these other nerves that are in these areas. So one of the best things you can do really is get out an anatomy book with nerve fibers, and when people start describing their pain, basically look and see, do we have any nerve fibers that run in that distribution? So venous status can occur really quickly. It's quite amazing. So if we stretch a nerve by 8%, that is enough to stop that venous drainage. Well, we said earlier that the ulnar nerve bends 55% just to do elbow flexion. So you can imagine, actually, if I'm working at a desk and I've got my elbows bent, if I sit there for a while, we can start to see why things like cubital tunnel syndrome is so common, or carpal tunnel syndrome. I have my hands resting on the desk. I don't need to restrict the blood flow a lot to start get a change in those nerves. So here's a fun thing for you to do, or a horrifying thing for you to do, depending on what you find. If you take your hand and take a piece of paper or something soft, you could take a pillow or a tissue or something, or whatever you have, and now just run that tissue down one finger, compare it to the other, and then compare it to your palm, and just see, can you feel a difference? So in theory, they should all be the same, right? They've all got a similar level of innervation. They've got a very similar level of representation in the brain. So they should all be the same. But what a lot of you will find is that ulnar nerve distribution is reduced from years of us being in a flexed position, years of using your phone, years of being on the computer, years of holding a phone to your head. So that ulnar nerve has taken a lot of abuse getting stretched through that, over the elbow, through that cubital tunnel. And so you may well find that one side is reduced, and I certainly do. So hopefully it's just a minor thing, but for some of you it might be significant. So when we have this repeat blockage of this venous outflow and we have edema, we start to get inflammation, and unfortunately that inflammation is going to lead to fibrosis and scarring, which basically is going to increase the chance that you have tethering, or that we get compression further. So it's a bit of a cruel trick, really, that once the nerve starts to get damaged, it's more likely to get damaged. I mean, it's like that with all health, really, isn't it? Once you start showing signs of aging, things go, once you have a knee injury, let's say you tear your medial meniscus, we know you're far more likely to go on to have osteoarthritis. So it's a bit cruel. So that hypoxia leads to inflammation, fibrosis, demyelination, and axonal degeneration. And we'll talk about why in a second. Now, when we're talking about demyelination, the things that we see in clinic, in fact, let's do a little quiz, and if you guys can pretend you never saw those answers. When we look at this demyelination, that is going to come on fairly late in chronic neuropraxis. So in things like carpal tunnel syndrome, cubital tunnel syndrome, or things where people are just maintaining certain postures a lot, demyelination actually occurs fairly late. So what we're going to see initially is far more of this kind of cycle of venous stasis, edema, maybe temporary pain, aching, numbness, tingling, gets resolved when they change position or move or stretch, and then this nerve goes through this repair cycle. As that starts to occur more and more, we start to get fibrosis, we start to get scarring, the nerve can't repair itself as efficiently, it can't function as efficiently, and then as that nerve really starts to fail later, we get the demyelination. Once we have demyelination, once the axon is then no longer protected by the myelin sheath and the Schwann cells, that's when we really get axonal degeneration. And you will see that commonly in your older patients. So if you go and test vibration in anyone probably over the age of 70, you're probably going to find reduced vibration sense in their feet, starting with S1, like S2, S1, L5, L4. So basically, the longer the nerve is, the more likely it's to be damaged. And that largely comes from a lifetime of sitting on that nerve, stretching that nerve, compressing that nerve, walking on that nerve. You think the whole lifetime these nerves are subjected to mechanical strain. And that's just, that's in a golden scenario. So once you add in smoking, drinking, bad diets, chemicals, pollutants, all these things, the longer the nerve is, the more vulnerable it is. So some of these nerves going from your low back to your feet, they're meters long. So they are massive. So they are the ones that get damaged first. This is why often if we have some of these ascending polyneuropathies, some of these horrible genetic ones that really take out everything, like stockings and gloves, everything regresses. The sensation that is often the last to go is the sensation down spine, where we have these very short little branches that get sensation, but literally kind of along the paraspinals. So because they're so short, they don't absorb as much. It's like whales in the ocean or the apex predators absorb all the toxins of everything else they've eaten and die more quickly than like a rat. So a rat won't die from poison, but the owl will. It's like that with nerves. So these longer, bigger nerves are more likely to get damaged, which is why we lose vibration sense. Vibration sense is highly myelinated. So once the myelin starts to suffer, that's why you lose it. Then we go to soft touch soft touch and textures. But the unmyelinated pathways, that kind of pain and temperature, they go last because they don't have they're not as big, they're not as fast, they're not absorbing as much, they don't have that myelin sheath. So neuropraxia. See what I did there? I kind of just garbled on for a while to hope you guys forgot that I put up some answers, but I didn't mean to put up. So neuropraxia, we have 3 main types of nerve injury. I've said the word neuropraxia enough. So can you write down on a pen and paper or say it out loud, commit to the answer. Is it the least or most severe type of neuropathy? I'll give you a few seconds and I want you to commit to an answer, because if you get it right, you're a hero, you'll remember it. If you get it wrong, you'll weep and you'll remember it. And if you don't commit, then you'll forget both. So neuropraxia is the most mild form of nerve injury, and we see improvements within days to weeks. So typically 2 to 3 months for full recovery. So that's 2 to 3 months once you've removed the insult. So carpal tunnel, let's say I like sleeping like this, and I also like doing DI work during the day using lots of vibration, and I also like playing squash and tennis where I'm really kind of whipping the wrist back and forth. If we then said, right, you're going to take a break for a couple of months, you're not going to play tennis or squash, you're not going to do DIY tools with vibration, and you're going to wear wrist sprints, we've removed that mechanical trauma, we would probably see a full recovery within 2 to 3 weeks, 2 to 3 months. Now, if it's mild or just slight, you might see recoveries within hours or days. It can be really rapid. Sorry, I said hours, but within days to weeks. When we use our lasers, this is one of the areas that is really exciting to use it on. So anyone who has like a slight or mild neuropraxia, we know that in neuropraxia, the myelin sheath is completely intact, all the connective tissue is completely intact. It's more like I'm going to say the word nerve block, but that not like an injection, right? So let's imagine I'm playing rugby and I've had that stinger. There's temporary dysfunction of how that nerve can operate, but all the connective tissue is still there. So if we have temporary edema, it swells, it cuts off the nerve, it can't work so well. So if we can come in and use a laser, reduce that pain, reduce that inflammation, promote healing, we can see really rapid changes. Now, neuropraxia can be moderate or it can be severe. And once we get into that severe range, that's when we start to really damage the myelin, we start to lose that myelin, and maybe even get that axon degeneration. In which case, we can't just laser it for over the course of a few weeks and expect to see that fully recover, because the actual axon is damaged, the nerve, the actual myelin is damaged. But in these kind of mild to moderate cases, you can see really exciting changes. So I recently saw a guy who has polyneuropathy in both feet, and he hasn't got there's no official cause for it. So they can't say it's from diabetes or alcohol or toxins, or there's been that he hasn't had cancer and had to have radiotherapy or anything like this that may damage it. He just has this polyneuropathy. This is sensory motor polyneuropathy, and he's had nerve conduction studies that have shown it's sensory motor, but clinically it's only sensory. So he only complains of discomfort in his feet. The reason is the myelinated pathways have gone or are going, so he feels pain far more easily. So if you imagine every time you put pressure on your feet, the weight of your body is enough to activate those pain fibers. So every time I step onto my right foot, my foot says, ow, I'm stepping on something, I've got a weight coming through me. Now, as long as I have normal soft touch and vibration, those myelinated pathways are much bigger, much faster, and they should inhibit that pain at the dorsal horn and spinal cord. So as the pain comes up, hits that dorsal horn and spinal cord, those other pathways are going to say, shh, he doesn't need to know about it. At the same time, I have this descending inhibition from my brain to say, hey, I recognize my foot is healthy, I'm just walking, it's totally normal. When we lose these myelinated pathways, now we haven't got two people on the phone, one much louder, much noisier. Instead, we just got that quiet voice that says, ow, every time I take a step, because the brain is losing its afferentation and it's no longer got a great map of where the foot is and that the foot is healthy and it's getting to inhibit pain. These pain signals are allowed to come through more regularly. So when he comes in, he's complaining that every time he walks, he's getting this, it's like walking on, he says it's like walking on sand or on pebbles all the time. So it doesn't matter what shoes he wears, what socks he wears, whether he's walking on actual pavement or grass, every step is causing him discomfort. So we did laser with him 3 times a week for 2 weeks, twice a week for 2 weeks. And on day 1, he couldn't feel vibration until the middle calcaneus, so the middle ankle, medial ankle. And after 2 weeks, after a month, he could feel it about 2 inches further along. Now that's quite cool because a nerve can only regrow a maximum of about 1 inch a month, and that's if in your young, healthy years. So when you're in your 60s, probably 1 inch a month is overly hopeful. So if we've got now vibration sense 2 inches further down his foot, it probably isn't that the myelin has regrown in that time. It's probably that the nerve has been struggling. We'll go through some terms in a moment called neurotrophic factors and axon transport, or axon flow, it's sometimes called. Probably those aspects of the nerve were failing. The nerves couldn't operate properly. And when we're using the laser, we're reducing that pain, reducing that edema, reducing inflammation, and allowing the cell to have more energy to start producing proteins, lipids, neurotransmitters and things like that. And that's why the nerve starts to operate more smoothly. So it won't be that the nerve is fully healed yet. It physically can't be, and yet you still see this improvement. And beautifully clinically, that goes along with his sensation. So he's now saying he can walk comfortably. It's doing much better. So I'm now taking a month break with him, letting those benefits just continue. He's doing some exercises, balance exercise, strength exercise, really trying to stimulate that nerve at home. We have to stimulate nerves to keep them healthy. And you can imagine as his feet hurt more and more, he's been wearing thicker and thicker soles, thicker and thicker socks, trying to protect his feet from the pain. So instead now we're doing the opposite. It's trying to go back to thinnest footwear now that he can tolerate that touch to try and really stimulate those nerves. So axontomesis, is that the most severe or the middle severe? So is it moderate or most severe? And again, out loud, write it down, commit to an answer. Okay, and for bonus points, what is it? So if neuropraxia was that all the connective tissue is still intact, what is an axontomesis? So an axontomesis, it's that the axon is damaged, but all the connective tissue is still there. So the endoneurium, the perineurium, the epineurium is all there, but the axons have been damaged. And often that's going to be through a crush injury. So we have a crush where the actual internal part of that axon is damaged and it needs to regrow. Now it can repair, but it depends on how severe the injury was. Now we're going to get approximately 1 millimeter, maybe 2 if you're in your golden years. Golden years is older years, isn't it? If you're in your younger years, maybe 2 millimeters a day, but it's slowed down by everything like lack of sleep, smoking, drinking, lack of poor diet. All these things are going to slow that down. So we're hoping for 1 inch per month. Because the axon is damaged and it needs to regress and then regenerate, the recovery is going to take months to years. But the good news, it can do it. So last question, what is the most severe form of nerve injury? So we've had neuropraxia, we've had axontomesis. What is the most severe form? And again, say it out loud, tell your partner if they're in the room. If you're feeling brave, put it on Facebook, let the whole world know you're doing it. So a neurotomesis. So this is where we're going to sever the nerve, and it's the most severe by far. So a neurotomesis, the entire connective tissue is severed. So epineuron on the outside, perineuron in the middle, endoneuron in the inside, all of that is gone, including the axon. So you're going to have surgery for this, and even with surgery, it's not a guaranteed win. So it'll take a minimum of 6 months, but it may never come. And unfortunately, I'm sure there is a level of skill with this, but it seems to be, doesn't matter how skilled the surgeon is, you could do a perfect transplant or reconnection. It's just down to you and whether it takes. So better outcomes are associated with being younger, so under the age of 25, distal nerve injuries, rapid repair. So that means that I'm doing DIY at home. I have an accident with a bandsaw. I take myself straight to hospital, and the world's greatest surgeon is there to do it for me straight away. Not that a week later I think, I should get this looked at. So signs and symptoms. The vast majority of what we're going to talk about now is neuropraxia, because that's what we see. So paresthesia, so numbness, tingling, or altered sensation, aching, weakness, and it's generally going to be relieved by changes in position and movement. When it's more severe, that might not be. So remember, these are on a grey scale. So initially, someone's going to say, I wake up with some numbness, tingling, or I notice when I'm in a certain position, I get this aching, this burning, and actually when I change, it goes again. But depending on the level of sensitivity of hyperalgesia, of nerve damage, those can change. So the paresthesia might go from, I get occasional numbness and tingling, to my hand is always numb. The aching might go from, it aches when I'm in certain positions, to I have this chronic pain. My hand hurts so much, you just lightly touch my finger and I feel it's extreme pain. When we get that peripheral sensitization with central sensitization, also known as primary hyperalgesia, which is where the injury site is more sensitive, and secondary hyperalgesia, where the non-injured sites are more sensitive. So when we look at, I love this picture because you kind of get a sense of these tunnels. So this is the greater occipital nerve, and this is one of the kind of common peripheral neuropathies or neuropraxias. So we can see the nerve passing up, and it's passing under these muscles here. So if these muscles are hypertonic, where someone maybe has a bad posture and their head's forward the whole time, or maybe they have a job where they have to look up a lot, where maybe like a tree surgeon or a surveyor or something, where they're looking up a lot, we can get this nerve compression of the greater occipital nerve. We get this venous stasis, we get edema, that swelling starts to build up. That might be temporary initially, but as that that swelling starts to build up and we get repeated inflammation, we start to get that venous scarring, scarring, fibrous tissue occurring, and later demyelination and degeneration. But the vast majority of people aren't going to get to that point. They're just going to be in that horrible pain state where they get that horrible aching at the back of the head, and maybe they start to get central sensitization. So now when they put their head on the pillow, it hurts. When we look at allodynia, so pain that comes from things that shouldn't normally be pain sensitive, we have diagnostic criteria for central sensitization for headaches, and one of them is literally the heat from your pillow causes pain. So people love, the cool side of the pillow. Well, if we get to a stage where you can't tolerate the heat from your own head being reflected back at you, we know we have a lot of pain sensitization, both in the nerve and in the spinal cord and brain. So we have these kind of things all over the place, and once you, we haven't got time to go through all of them today, but once you start digging out textbooks and looking at things, you'll see that these kind of tunnels are all over the place. Another one that you can look at yourself is if you look at the supraclavicular nerve. So if you take your finger and get onto the clavicle and just run your finger back and forth, at some point you'll feel, almost feels like a copper wire, like quite a flat copper wire that goes over the nerve. And if you press that, for some of you that might be quite tender, it's the same thing. We've got this nerve running right over a bone. So if we have these changes in posture, where that nerve is now is not in its ideal situation, or we've got some compression a little bit higher when we have a double crush. So maybe we have a bit of thoracic outlet syndrome through the scalenes, where a nerve is compressed in one place and that axonic flow starts to fail. Basically the health of the nerve starts to fail. It's more likely to get compressed somewhere else. We'll talk about this in a minute because I'm getting ahead of myself. So we want to when we're treating back pain, neck pain, things like that, I would really encourage you to start looking at these nerve pathways and trying to trace them. And it'd be amazing how often you'll find that someone literally you'll with your thumb just trace the entire way down that nerve, particularly over the low back. So we can use laser. I would use it for a minimum of 5 minutes. So when we're trying to use these things, whether it's at the carpal tunnel, on the back, or the occiput, it's always going to be a 5-minute session to see a significant improvement. And what you should see is you're going to test it. So you don't just send the person off and tell them, hey, you can't feel anything happening. You can just see a light, or you can't even see the light. I'm shining on the back of your head. Off you go. Just make a point of always compressing the area first, getting them to commit to a number. So on a scale of 0 to 10, 10 being the worst, how painful is this? Poke. And they'll say, it's a 7 out of 10. Laser at 5 minutes. At the end of 5 minutes, poke again. You'll normally see it reduced by half. When it doesn't, that is a clear sign that you have secondary central sensitization or secondary hyperalgesia. So the pain system has become very, very aggressive. So I saw a gentleman last week. He has cluster headaches every single night. So every single night he wakes up with these just debilitating headaches. With him, around that occiput was just incredibly pain sensitive. So it didn't matter how when I did the touch the first time, he was like, oh, it's like an 8 out of 10. We laser for 2 minutes. Normally after 2 minutes, you already see a pain reduction. Nothing. It's like, no, to be honest, I can still feel where you poked. So as soon as someone says, I can still feel where you poked, that means that secondary central sensitization. So I've been looking after 2 kids all day. My brain is obviously frazzled from answering 1,000 questions. We have spontaneous discharge. So a nerve can become so aggressive and so sensitive that when you press, there's so much neurotransmitter released into the synaptic cleft at the dorsal horn and spinal cord from the primary to the secondary neurons. So the first order neuron to the second neuron. So the first order neuron is trying to say tag, get that signal across the cleft to get the signal from your spine up to your brain. So that, in his case, that synaptic cleft has become so aggressive and so sensitive to that neurotransmitter that when neurotransmitter is just left floating around the cleft, when it just happens to bump up against the second order neuron, that stimulates pain again. Well, normally that should not be enough, right? Normally we should have microglia and other supportive cells clearing that stuff out from the synaptic cleft. So the nerve should transmit the signal, you should get an action potential, and then all that transmitter should be used up or actively cleaned out, because you don't want spontaneous feelings. You don't want to suddenly think, ow, my face hurts, or oh, I felt a wind on my shoulder when there was nothing, right? When we have this central sensitization, we don't have that response anymore. Inflammation is everywhere. Microglia, astrocytes are pumping out information and saying, yeah, have at it. Tell them as much as you want. So I poke him, and literally 10 minutes later, he's like, oh, man, I can still feel exactly where your thumb was. So in that case, we're not going to see a significant pain reduction in 5 minutes. In those cases, you want to be doing at least 10 minutes, but you might even do a full 15, which is a long exposure with laser, but with these Erchonia lasers. But sometimes that's what you need to do. So when we're looking at things like this, we've got the supraclavicular, oh, I said the wrong word there, didn't I? No, I'm saying the wrong word now. Again, 2 kids, sorry. Supraclavicular is what I said here, that was correct. Suprascapular nerve coming at the back here. So suprascapular nerve is going to come through this suprascapular notch. It's basically a ligament and then bone. Now, this is another kind of classic entrapment site for peripheral neuropathy, and what you're going to get is this proximal shoulder pain. So the interesting one with this is, again, if we have this double crush or maybe a reverse crush, which we'll talk about in a minute, you will see cases, and I'm sure you'll recognize the story, that you'll see someone with a clear cervical radiculopathy. So they have the neck pain, the pain gets worse when they turn their neck, that pain refers into the shoulder and goes down the arm. So you have this classic symptom. You maybe look at the arm and you're like, oh yeah, you have actually got a bit of sensory loss there. Reflex is a little bit altered, strength is not quite what it should be. So we've got definitely a cervical radiculopathy. You start treatment, and after maybe 6 weeks or so, they're like, actually, my neck's doing really well. I'm not getting pain from my neck anymore. My hand's feeling really good. Strength is back. Sensation is normal. Like, it's looking really good. My shoulder really hurts. And you get this clear impression that actually the neck's looking really good. The nerves in the arm seem to be doing really well, and yet they have a legitimate shoulder problem. They can't raise their arm up. It's tight. It's stiff. When you palpate, that supraspinatus and infraspinatus, that, oh man, it's really sore. What can happen there is this double crush idea that we had, let's say a C7 radiculopathy. We compress that nerve root, and because the nerve root is compressed, we have this reduction in axonic flow. The nerve is no longer as healthy as it used to be. Basically, I'm jumping ahead of myself, so I do apologize, but it's an important part of the story now. So if we think of a nerve, a neuron, as it's an individual neuron, sorry, as its own living being, right? So we've got a cell body. The cell body is where everything is made. That's where we have mitochondria, which we have the nucleus. We have protein production. Everything that's going to be important for that nerve, for that neuron to stay healthy, is in that cell body. The cell is full of a medium, and in that medium, we've got these microtubules. They're basically like the highways that allow you to transport stuff that's made in the cell body all the way down to the other end of the axon. So again, if we go to the leg, these axons are meters long. So you can't just have a blood supply around it and hope that all the nutrients and energy that you need can just diffuse into the cell, because it's too long, it's too big. So we have to have production in the cell body, and we have these things called motor proteins. And the motor proteins will basically bind to other proteins or anything that's been made, and then transport it along the axon to where it needs to go. And then at the other end, we have proteins and other things that need degradation. So these motor proteins will bind to them and again walk them back to the cell body to be broken down and recycled. So it's a bit like us. If we take a step back and we look at our whole body, we have this circulating blood system taking things out to our peripheries and bringing things back. Well, our neurons are like that as well. So if we have a compression and we have edema compressing the nerve, and now we can't get these things flowing down to one side of the cell and back up the other end, the cell itself will start to suffer. So if you put a compression band around my arm and tighten it and tighten it, and now I can't get the blood to my hand, pretty quickly my hand's going to start to die, and it's the same with the nerve. So when we have a crush maybe up at the nerve root, that cell itself is not as healthy as it used to be. And of course, the radiculopathy, it's all shades of gray, right? So when we start to touch the nerve, we may just have pain and a little bit of compression. As we start to compress it more, we start to get sensory loss, then we get motor loss, and then we get real damage. So if we just have enough sensation there that the nerve is losing a little bit of that axon transport chain, then the cell just isn't as healthy. And when it goes through other tunnels that might have a little bit of compression as well, then everything blows up. And that's another classic one you see in the low back. So someone might have like a radiculopathy, again, like an L5 radiculopathy, and they've got pain coming down the back of the leg, comes to the knee, goes down the front of the leg to the top of the foot. You think, yeah, classic L5 radiculopathy. Their back pain starts to get better, and yet they're still like, my knee really hurts. You'll often see this peroneal nerve compression at the knee as well, common peroneal nerve compression. So these things can occur. They can also be reverse crush, where because we have a peripheral nerve compression, maybe at the carpal tunnel, we're more likely to get more proximal nerve compression, maybe at the nerve root. Another good reason to test these things, especially if we, a lot of us like to use the word holistic. So if we're looking at holistic things, we need to do good assessments for our sensory motor and reflex testing. So why does the nerve really hurt? So when we have, let's talk about sensory nerves, because it's a little bit easier to work with. If we damage the afferents coming from my finger to my spine, we have sensory loss. So that makes sense, right? The nerve cannot transmit that information. Obviously, we have sensory loss, but we also have pain. And we have pain because that cell body, to stay healthy, has to have this flow going back and forth, but it also needs stimulation. So again, if we look at us as a whole body, we call it trophic factors. So to have the cell that neuron has to have trophic factors to keep it healthy. Trophic factors basically mean things that allow it to grow, repair, and perform its functions. But we have trophic factors. So an obvious thing would be we need clean air to breathe, we need clean water, we need healthy food. But you could take me and put me in a perfect isolation chamber where I couldn't move and I had no sensory stimulation whatsoever, but still give me somehow clean water, clean air, clean food. I would still degenerate and die very quickly, right? The missing thing is I need stimulation, and neurons are the same. Neurons can't just have the building blocks, they have to be stimulated. So the tissues that those neurons connect to, let's just say skin for now, produce neurotrophic factors, so nerve growth factors and other chemicals that keep that nerve healthy. So the skin literally says, thanks, buddy, here's some money for your troubles, thanks for talking to me. When we damage that nerve, or that nerve gets compressed, and we have that separation, that information, those neurotrophic factors can't get from out in the periphery back to the dorsal ganglia to supply dorsal root ganglia to tell that, to keep that nerve healthy, so the nerve will start to fail. Now, when cell bodies don't get stimulated, they start to swell and they start to become very jumpy. So you get these ectopic activities. So think of ectopic beats, your heart starts beating its own rhythm, doing what the hell it wants. Or another example would be tinnitus. You know, you damage the hair cells in your ear, and then cruelly, you start hearing the noise you can no longer hear. I mean, it's just cruel. So it's the same with pain. My hand has gone numb, and yet it starts to hurt. And the reason is these cell bodies start to spontaneously discharge because they're no longer healthy. So we have disruption of the axon transport system that we talked about. We have reduced neurotropic factors we talked about. We have increasing of inflammation, and we have a loss of normal signaling mechanisms from target tissue. So that's everything we just talked about. So let's just skip through that. Hyperalgesia we talked about earlier. So hyperalgesia, let's say we're in an early phase. Let's jump to a nerve injury. Let's say I damage my suprascapular muscle here. The tissue that's injured will become hyperalgesic. It has to. So in order to give that muscle a rest and let it recover, I don't want you to move my arm around. I don't want to be lifting weights a lot initially anyway. I want to just let that muscle heal. And that's what the primary hyperalgesia is for. So that's going to occur with a nerve injury as well. So we're going to have a rush of inflammatory processes that are basically going to increase inflammation. The problem is that inflammation can mean that the peripheral nerve, the surrounding peripheral nerves that haven't been damaged, become upregulated, and they start to transmit pain quicker. So they literally can zip that pain signal along those slow pain fibers faster. So they will get faster at doing that, and they'll start doing it more spontaneously. When the dorsal horn of the spinal cord starts getting hit more regularly with pain signals, it will start to change. So normally you have far more pain inhibition than you have pain excitation. So it's far easier for me to inhibit pain than it is for me to feel pain. So again, if you take your own thumb now, you start pinching really hard. You have to pinch pretty hard before you start thinking, yeah, I'm feeling pain from that. But if you ask someone else to do it for you and ask them to pinch your thumb, you're going to say ouch much faster. So if we looked at the amount of pressure you could take before you said ouch, the amount of pressure that you applied would be far higher than the pressure they could apply. So what we see in primary hyperalgesia is these reduced pain pressure thresholds. That means you take less pressure before you experience pain. When that happens a lot though, we have these secondary changes in the dorsal horn, spinal cord, and in the brain itself, so that the non-injured adjacent tissue starts to hurt more. So initially the injury is here and this hurts, but now actually all around my shoulder hurts. You petrol around here it's sore, and as that gets worse, it starts to spread. And we have the same thing with peripheral neuropathies. And that's why sometimes diagnosis can be very hard, because someone might present with something that looks very simple, like maybe you think, oh, it sounds they're like a tennis player, and it sounds like pronator teres syndrome, so they're getting compression of the median nerve at the wrist, at the elbow. You think, yeah, that's where the pain started. But now they have pain radiating all the way down into the wrist. And you think, well, actually, now it also looks like carpal tunnel syndrome. But it's also maybe in that C6 dermatome. So which one is it? And like we said, we could have double crush. So these things get complicated. So in an ideal world, the gold standard is to have, electrodiagnostics, but most of us don't have access to them. Also, the problem with electrodiagnostics is people are different. We have different nerve pathways. There are different anatomical variants. So sometimes you get false negatives. Or people do surgery and based on those things, and they really shouldn't have. So secondary hyperalgesia, we talked about this. Let me skip through. Man, I've been talking way too much, far ahead of myself. So again, because of this double crush theory, the idea is that we have this axoplasmic flow is reduced, so that the actual cell, the neuron, can't stay healthy. Because it's not healthy, it starts to suffer at different places more easily. This is cool. So scratch collapse test. This was originally created for ulnar nerve compression at the cubital tunnel, and then it's been used more widely for things like, well, any nerve neuropathy. So it's a fun one for you to play with. Now, the only problem with it, a big systematic review from last year has found that it's not very sensitive. So it's only about 38% sensitive. That means you're going to miss a lot of, you're going to get a lot of false negatives. So you can miss a lot of positive tests, but it's extremely specific. So when it is positive, it almost certainly is you found the correct. That's it. I'm just wording this terribly. Let me try that again. If you do the test and it's negative, it doesn't mean that there's not a peripheral neuropathy. If you do the test and it's positive, it means it almost certainly is a peripheral neuropathy. That's the better way to say it. I wish I said it the first time. So the way we would do this test is you can have someone basically, can you see me okay if I just stand up a little bit? You can have someone try to externally rotate their arm and you're going to push against it. Now, while they're holding that, you're then going to come in and you're just going to give a little flick across the nerve entrapment site. So if you think it's an ulnar nerve at the cubital tunnel, you're going to come and give it a little flick. And what you'll see is as they're pushing out to your hand, when you flick, the hand will suddenly collapse. This has been now experimented with headaches, with like greater occipital neuralgia, with migraines, with all kinds of different things. So it's quite a fun one. It's quite interesting. When you do find it's positive, get the laser on there and see the difference. It's really fun. So I think this is quite a cool test because certainly in manual therapy, certainly chiropractors have been using muscle testing for forever. And a classic example would be, muscle test, then touch the level or the joint that you think is involved, and then see that muscle go weak. And actually, this test was only brought out in 2008, but because it was done by medics and not chiropractors, it had a whole bunch of research done on it, and maybe a little bit more. It's maybe a little bit more accepted the rationale about why it works. So the idea is that when that nerve is being compressed, we get hyperalgesia, we get changes in protein states, we get inflammation, and effectively we get withdrawal reflex. So as the person's holding and activating muscles, when you create that hyperalgesia, because you're not like scratching their arm, although it's called scratch, you're flicking it. So we just flicking the tissue, that hyperalgesia causes a nerve reflex. So a signal comes up to that level of the spine and inhibits those motor fibers. So we get the arm suddenly collapses. Now, in theory, you could do this with any way, so it doesn't just have to be external rotation. You could activate a muscle, flick a thing, and if you see it suddenly reduce, that's going to be the same response. So yeah, there's quite a lot of interesting research on this one. When you do find a positive, it's going to be a positive nerve entrapment, and then what you're going to do is just laser over the area that you deflect. So if it was the cubital tunnel, you'll laser over here. You could do it at the carpal tunnel, so you could do have someone do like a opponent's polysis where they're doing these kind of things. You could have them hold, and then flick across the carpal tunnel, and if you see it something goes weak, it's the same thing. Then laser wherever you flicked. So that's quite cool test. So hyperalgesia leads to inhibitory spinal reflex, and it's effectively thought to be like a withdrawal reflex. So I've been talking far too much, so I apologize if I've been talking a million miles an hour. There's quite a lot to go through. In Manchester, we're going to be doing this. So not just this, but we're going to be going through this in more detail and going through kind of the wide array. Today, we're going to go just through the most common ones, but the ones you can see in clinic and hopefully recognize more regularly. So carpal tunnel, obviously, carpal tunnel syndrome, the most common and the heavyweight that we all know about. Now, I have bashed my head against the wall so many times trying to learn all the muscles that the median nerve innervates and where to test them and how to test them and all this kind of stuff. And really, it's overcomplicated. All we need to know is the median nerve is going to come down and give us sensation to the palm, the radial aspects of the palm, and these 3.5 fingers. So in carpal tunnel syndrome, the palmar branch comes off before the tunnel. So in carpal tunnel, we only have these 3.5 fingers. The palm is spared. So 3.5 fingers are numb or have altered sensation, but the palm is fine. When we're doing muscle testing, we're going to see weakness of the opponents. So the ability to oppose my thumb against different fingers. So very simply, you can just try it against different fingers and see if we have a weakness there. Okay. So really, actually, when it comes to testing the median, ulnar, and radial nerve, you can just look at the thumb for all of them. They each have an aspect on it. So for the carpal tunnel, it's going to be opponent's polysis. or you could use flexor pollicis brevis. The only issue with flexor pollicis brevis is that it does have an ulnar innervation as well, so it's mainly median. But if you want a better option, opponent's pollicis is your guy. Sorry, I said that wrong. Adductor pollicis brevis. So this one here it looks pretty similar, right? This one here has a slight ulnar deviation, so you could use this one instead. So flexor versus opponents, but opponents I think it's easier. Now the nice thing to remember with this is if we have the injury isn't at the carpal tunnel, but it's maybe the pronator teres syndrome, it's very similar. It's can you make an OK sign? So with this, it's flexor pollicis longus. So this is a branch of the median nerve called the anterior interosseous nerve. It's purely motor. Now, pronator teres syndrome is right up here. It's where the nerve is going through the two heads of the pronator teres, and it can get compressed there. We're going to have that sensation loss in 3.5 fingers and the palm, right? Because the cutaneous branch to the palm is still running with it. Now we have interosseous nerve syndrome, which is where this big branch that comes down and does most of the thenar muscles, the thenar muscles that can move the thumb. You could have a compression injury there. So let's say again, rugby player goes in for a tackle and hits someone here. He might present with no sensory loss, but just weakness of the thumb. So again, this time you're going to find he can't make an OK sign, but he also can't oppose his thumb to other things. So really easy, right? Can you oppose your thumb? No, it's at the carpal tunnel. Okay, you can't oppose it. Can you make an OK sign? Yes, you can. Fantastic. Carpal tunnel. You can't make an OK sign. Okay, it has to be before the carpal tunnel. It's median nerve, either pronator teres or anterior interosseous. On the nerve, cubital tunnel syndrome. So this is the second most common in the upper limb. Again, really simple. It's going to be the 4 and 5th, 4 and a half, 5th and half of the 4th for the palm. For the fingers, but not the palm. So, oh God, guys, let me take a drink of water and just try and get my brain working again. It's a 3-year-old. She's the tricky one. So, the cutaneous branch comes off before the synovium, before the wrist. So we're going to have in cubital tunnel syndrome, we're going to have the palm and the fingers are numb. They have altered sensation, might have paresthesia or whatever level. We're going to have weakness of flexor digitorum profundus. Now, digitorum profundus is another good one for testing for carpal tunnel because it comes off, it's way up here, up the elbow. So we have a radial branch, we have a median branch, so we have an ulnar branch. So if the ulnar branch is damaged at the elbow, we're going to see weakness of these fingers. And just generalized grip strength is going to be reduced. So the ulnar nerve is called the artist nerve. It's the one that allows us to have all this fine coordination and really do fine detailed things. The other test you could do is can you cross your fingers over? So can you make an OK sign? I hope it's okay. Or, fingers crossed, fingers crossed you make an OK sign. OK is going to be median nerve, crossing your fingers is ulnar nerve. So you could ask someone very simply, can you cross your fingers over? If they can't, probably ulnar nerve is not so healthy. And then we can ask them they can hold it, you can try to uncross it. But I think it's easier just to make them to make a claw and just hold here. The tunnel of Guion is the next common one. You're going to see this one more in cyclists, so people who have their cubital tunnel compressed by cycling for long rears, or people who work at a desk again, hand on a bit like carpal tunnel. So this time it's just going to be the 4th and 5th finger. So the palm will be spared, but the 4th and 5th finger will be numb. And when we're looking at weakness, again, it's going to be grip strength. Again, can they cross their fingers? But the other one that's quite nice is Froment sign. So again, if you want to forget all this stuff, just think about the thumb. So if you forget everything else I've just garbled out, just think of the thumb. Median nerve, can you oppose your fingers? Can you make an OK sign? Ulnar nerve is adductor pollicis. So Froment sign. So the classic one would be, put a piece of paper or a pen in here, have them pinch and see if you can pull it out. So that's the only one you need to know. The ulnar nerve is going to come round. It comes here. Can you see me? Yep. It's going to come in through the cubital tunnel. It's going to come all the way around, and the final stop is going to be adductor pollicis. So it's a really nice, easy one to remember. Another one, if you want to just remember ulnar nerve, is the adductor digiti minimi. It moves the little finger towards the ulnar nerve, right? So towards the ulnar branch. So really, really simple, right? So we can either just say this one is on the ulnar side, on the ulnar aspect, or it's all about the thumb. Again, it's moving the thumb towards the ulnar nerve nice and easy. It's actually quite interesting because each of these nerves, you can break it down much further. So like the cubital tunnel, you can argue there's 3 different entrapment types there. We can argue that each of these nerves, median, ulnar, and radial, has 3 different entrapment sites. And I spent a lot of time trying to hammer those into my brain. And the fact is you just don't see them. So for the radial nerve, for example, one of the big ones is the spiral groove, like at the back of you see this one up the top, the yellow one at the top there. When do you see that? When someone breaks their arm. That's basically it. So either someone has to hit me with a bat in the back of the arm, well, that doesn't happen very regularly, or I have to break my humerus. And when the humerus breaks, the ulnar nerve is running the spiral groove, literally attaching onto the bone, and it can get damaged there. So really, radial nerve is really easy. It's going to be supinated syndrome. Think of people doing DIY, or doing this kind of thing, or playing a tennis shot, over and over and over, practicing that backhand. So we can either have supinated syndrome where we have weakness and sensory loss. Radial nerve is beautiful because it's basically the back of the hand and not the distal fingers, because that's still median and ulnar, but radial nerve is going to be the back of the hand up to about here. So very simply, the back of my hand is numb. Well, that if it's the whole of the hand, that's not going to fit any one like nerve root. Really easy, it's going to be radial nerve. And if you haven't broken your arm or you've done some weird thing with your upper arm, it's going to be supinated syndrome. If it's supinated syndrome, there's a motor aspect to it, so it'd be wrist drop or weakness of finger extension. So really easy. But again, if you want to think of the thumb, just think of thumb extension, right? So can they bring the thumb backwards? Can you push it forwards? No. So we can do it all with the thumb, but wrist drop, finger extension, really easy through radial nerve. Now the radial nerve does divide, and we have a superficial radial nerve. So that's posterior interosseous nerve to oppose the anterior interosseous nerve of the median nerve. And that's purely sensory. So superficial radial nerve, that's going to purely give us a sensation to the back of the hand. So again, we have the same scenario, maybe an impact or repetitive strain. It just depends on which muscles are involved. Either I just have sensation in the back of the hand loss and I have weakness of wrist extension and finger extension, or strength is totally normal, but I have that sensory loss. Or if it's in its early stages, there may not be sensory loss at all, I just have aching. So a lot of these ones where we look at median nerve, ulnar nerve, or radial nerve, a lot of it's going to be pain, and that's why someone's come into you. I have elbow pain. So we basically want to search around, compress these joints, move the muscles, activate the muscles, and see if we can reproduce those symptoms at all. Both these syndromes are going to be commonly misdiagnosed. So tennis elbow, golfer's elbow, things like that, when it's actually a mild form of neuropraxia. The research on these things is nice though, because low-level laser has been shown to be effective in reducing peripheral neuropathies, and soft tissue work has been too. So whether you're using like myofascial release or whatever it is, works well, and research has shown that doing both together works well too. So they're a nice one to work with because you've got the manual therapy side of things is going to work. You want to try and readdress those compartments. So we might have that the anterior compartment is too strong, that they're too flexed. So we want to readdress, get those intrinsic muscles working properly, reduce those extrinsic muscles, get those compartments to be equalized. And then we want to do low-level laser to reduce that pain, reduce that inflammation, and it works really quick. It's really fun with patients because again, if you stick to that idea of poke it, get them to say ouch, laser it and poke it again, it is cool how quickly they'll say that their sensation is improved or that pain goes down. So you get a really easy win. It's a nice practice builder. I realize I've run too long, guys, so I will, if you let me just do this one, we'll finish up. So peroneal nerve is the most common nerve entrapment in the lower limb. Other ones you should be aware of would be myalgia paresthetica, which is going to be the lateral femoral cutaneous nerve, basically as it comes over the pelvis. Very common in pregnant women and things like that. The peroneal nerve, though, again, we have this double cross syndrome, so it's going to often look like an L5 radiculopathy, but it can come from basically using your foot a lot. So whether you play football or you do cycling or you're doing these like repetitive movements a lot, the peroneal nerve, common peroneal nerve is going to come down. So we've got the back of the leg, which is sciatic nerve. It's going to divide into a tibial and common peroneal, and then it's going to wrap around the fibular head. Where it wraps around the fibular head, it's going over bone. So again, we've got that fibro-osseous tunnel. We can have compression there, in which case we're going to get numbness and pain over the lateral aspects of the lower limb and dorsum of the foot. You can see it up here in the top right hand side of that picture. We're going to have weakness of all these muscles, but basically just learn anterior tib, so they can't lift their foot and they can't dorsiflex their toes either. So the one to look at there is that flexor digitorum, extensor digitorum brevis. So extensor digitorum brevis is highly innervated by L5. So it's a good one for testing in L5 radiculopathies. It's that one muscle you can really see on the foot. So if you look now, if you take your sock and extend your toes or dorsiflex your toes, you'll see that one really meaty muscle. That is the extensor digitorum brevis. So we're going to see weakness of anterior tib and extensor digitorum brevis as well. Now, just below that, from below the fibular head, it's going to divide into a superficial branch and a deep branch. That superficial branch can get entrapped between layers of fascia, and then we're going to get just the numbness. So not the weakness, but just the numbness. If it's the deep branch that can get entrapped by itself, we're going to get the numbness just between the first and second toe, but we're going to get more of the motor changes. Again, really important to go and check that when you're looking at a radiculopathy. And again, the beauty of this is basically find where it hurts, laser around the knee, a minimum of 5 minutes. Because we have different entrapment sites within that area, I would laser along those different entrapment points. So not just around the knee, but you want to then go and look at where the superficial site is and where the deep site is and laser those points as well. And that goes with the rest of the median nerves. Again, if we're doing carpal tunnel, it is just due diligence to then go and make sure that you've done soft tissue work at the elbow, make sure pronator teres is all nice and soft and loose, make sure brachioradialis is nice and loose, and you're going to laser the injury site. I'd probably raise it at the elbow and at the neck as well. So any other entrapment sites. We talked about this already. Now, I've kept you waiting too long, and I appreciate we've all got lives and we've all working busy days. So tarsal tunnel syndrome is the last one. It's pretty rare. It's worth knowing, but actually in terms of common nerve entrapments, it's actually a pretty rare one. So very quickly, entrapment is an osseous one. It's between this flexor retinaculum and this posterior tibial nerve that's going to give you sensation basically to the dorsum of the foot, to the sole of the foot. So we're going to get numbness or tingling or aching in the bottom of the foot. It can often look like a plantar fasciitis, but we're also going to get some motor weakness when it's more advanced in the ability to flex the toes. So that's the easy one to remember. It does a whole bunch of stuff, but just think bottom of your foot goes numb and toes. So there's a lot of information there. I apologize. I feel like I've spoken at 1,000 million miles an hour. If you have any questions, let me know. In Manchester, we're going to be going through these things, and we're looking at kind of neurological rehab, so neuromuscular rehab, and a section of there is going to be dedicated to peripheral nerves. We're going to go look at their pathways, look at the pain presentations, look at treatment, and get some hands-on and show you how that works. Undoubtedly, all of us have something. So if you have anything that's been an ongoing burning pain, that achy pain that you know changes when you change position or comes on in certain positions, most likely peripheral nerve, and we can do cool things with that. So I appreciate around 10 minutes over. I do apologize for that, and I hope it was worthwhile. Please do let me know if you have questions, and feel free to get in touch with any questions that you do have.
We don't have any questions at the moment. We had a huge amount of attendees, which is really good. I hope everyone has enjoyed this fantastic webinar. Thank you, Dr. Jake, for hosting this webinar tonight. You're very welcome.
No questions probably means I either did a wonderful job or a terrible job. So you can tell me in private afterwards.
It was fantastic. Thank you so much. Well, don't forget the recordings of this webinar will be sent out to all the registrants. And if you do have any questions further, please let us know. Thank you very much for attending. Have a great evening, and thank you for tuning in. Bye-bye.